Welcome everyone to our Wear Red Canada and Women with Heart, Lillian Love seminar series. We do these series usually quarterly, so we're really excited to have Dr. Abramson here to share some excellent information on menopause, heart disease, discussing the issues and debunking the myths. Before we get started, just wanted to tell you a little bit about what Wear Red Canada is all about. So some of you may already know this, but I'll just highlight Wear Red Canada is celebrated every year on February 13th across Canada, and it's really focused on raising awareness for women's heart health. We actually hold a number of events locally organized by our incredible cardiac rehab team, Dr. Lisa Cote and myself. My name is Tracy Kalala. We are co-chairs and we work with our team here at Toronto Rehab, UHN, but also with the Canadian Women's Heart Health Alliance. So you can see here, there's actually a link if you want to know more and register for some of the national events or local events maybe in your area. Please feel free to access that link, and you'll find lots of information there, as well as if you want to get involved in Wear Red Canada, there's opportunities there as well on the website. So I'll just highlight that briefly. Every event, we highlight our key messages around women's heart health. We know that heart disease is on the rise and the #1 killer of women worldwide. Some of these messages are very obviously stark, but men and women differ in the symptoms and how they present when they have a heart attack. And women also experience different types of heart disease than men do. And pregnancy complications, this is something that is relatively getting much more traction, relatively new in the last number of years, about pregnancy complications and earlier menopause being specific risk factors for women. And women with diabetes also have a 3 times higher risk of dying from heart disease compared to men. So these stats really reinforce the importance of becoming aware of your risk and understanding what you can do to help lower your risk. And the great news is that 80% of our risk factors are modifiable, and there's a lot we can do to lower the risk of heart disease. So wanting to share these, just to, please share this with your family, your friends, your loved ones, anyone who you may know who may be at risk for heart disease, because many women are unaware of that risk. We have the CN Tower here, our iconic CN Tower in Toronto. We just wanted to highlight on February 13th. I'm just going to talk about that momentarily before I introduce Dr. Abramson. We light up the CN Tower red in commemoration for raising awareness for women's heart health. So we're really excited about that. So if you're downtown on the 13th, look up to the sky and you'll see the CN Tower lit in red for Wear Red Canada. As well as across Canada, there's a number of different landmarks that are lit red. As I mentioned, this is a national event. We actually have a couple of other yoga local events, and I wanted to mention our yoga event on February 9th. As well as a fundraising lunch that we will be having. So if you're interested, please reach out to us and we can follow up. Finally, our national event. This is happening on February 13th, our Wear Red Canada official day. So wear red and celebrate the actual day in recognition of women's health through participating in this national webinar. The title is Women's Heart in Every Season, Protecting Your Health at Every Stage. And we have a number of amazing speakers from across the country who will be sharing their expertise. And you can register for this online, and you can see that there is a QR code there if you'd like to attend. This is available as well at the website, the Canadian Women's Heart Health Alliance website. So great. So without further ado, it's my pleasure to introduce Dr. Beth Abramson. And Dr. Abramson is currently the Paul Albrechtsen, I'm probably pronouncing that wrong, but professor in cardiac prevention and women's health in the Division of Cardiology at St. Mike's Hospital. the University of Toronto. As of July 2026, she will hold the chair in cardiology at the University of Toronto, focusing on preventative cardiology and women's cardiovascular health. Her interest is in knowledge translation, including writing guidelines to educate physicians on preventative cardiology and women's health issues. She's co-chaired guidelines committees, as well as focused on menopause and cardiovascular disease. She is the executive of the International Women's Health Academy and an invited author for the North American Menopause Society's Clinician's Guide. Dr. Abramson has served as a member of the American College of Cardiology Prevention Council, the Hypertension Working Group, and volunteers as a spokesperson for the ACC Media Relations. She's a founding member of the Canadian Society of Vascular Medicine and a founding member and inaugural chair of the Canadian Women's Heart Health Alliance Education Working Group. In 2015, she was awarded the prestigious Harold N. Segal Award of Merit in recognition of her many contributions to preventing heart disease amongst Canadians. And finally, her book, Heart Health for Canadians, published in 2013, was written to help people prevent and understand heart disease. And she is also director of the Fellowship of Preventive Cardiology at the University of Toronto for over a decade, and established a cardiometabolic clinic at St. Mike's Hospital to close care gaps. So we're really excited, Dr. Abramson. Without further ado,
it's a pleasure to be here. Thank you, Dr. Colella. I have to say, it's always a pleasure to be involved. Is this the next? So yes, slide. We'll get through the technical. Not a problem at all. This is my disclosure. I am not speaking about a compound or a drug. I'm talking about an issue, and I just put this up to make sure you understand that there is actually influence and influencers when we talk about menopause and menopausal hormone therapy and what we should be doing. But I am going to talk on information that is evidence-based and make recommendations that are evidence or guidelines-based. I do not follow social media. That's my disclaimer. I also am not an influencer. So I'm here to talk about your health and your heart health and the heart health of someone you love or care about. So we want to review changes in a woman's cardiovascular risk during the menopause transition and across midlife. We want to describe the role of Canadian guidelines, which I've written, in the management of menopause and the use of hormonal therapy, and discussing emerging and newer approaches to menopausal hormone therapy. Because I am aware, as we see people online and potentially here in the audience tonight, and across Canada actually, on this webinar, that there are people who are living with a lived experience of heart disease. And if you are having symptoms, we'll go over, of severe symptoms of menopause, there are actually newer options out there if estrogen is not necessarily appropriate or safe. Okay, so this is the facts. The average age of menopause in Canada is about 51 years. It varies across the world. And by 2025, there were, I had to change my slide to past tense, 1.1 billion postmenopausal women worldwide. So if we're not taking charge of moving the science and making sure the facts are right, we need to, because it's a major health, it's a major economic issue for the world. And there are many systems that are affected during menopause. And I am not going to go into all of them today, but I will show you, and I don't know if this mouse does show, there can be cognitive issues, skin issues. We talk about metabolic issues, bone issues, but we're going to focus on the heart, okay? And we know that women and Canadian women do have symptoms of the menopause. And when they're going through a transition in midlife, about 2/3 who are surveyed will say that there is a problem related to a hot flash or a flush, people call it both, and sleep disturbances and night sweats. Now, how long that lasts and how severe they are is variable, and some women do not have symptoms, but most women are affected in some way by the menopause, and we're going to go over this. The other thing, and I really am, this is the focus of my talk today, is that one's risk for heart disease increases after menopause. There's a higher cardiovascular risk for menopause caused when someone has a bilateral oophorectomy, salpingo oophorectomy. That's just a woman's ovaries are taken out without estrogen replaced compared to natural menopause. That's actually a fact. And we know that there's data. My colleague and friend Rebecca Thurston in the States runs this SWAN study looking at risk and risk factors across the transition of midlife for women, and has shown that there's an increase in more atherogenic subclasses of the LDL. I know we have healthcare providers and lay people who are informed about their health here, and the lousy cholesterol is the LDL cholesterol, and there is more dangerous LDL or lousy cholesterol that we see in women after they go through menopause. And we see worsening markers for future risk. So the carotid IMT, the thickening of our arteries in the neck, it is a marker for future risk. We see that in cardiovascular risk in women, and we see more coronary artery calcium. We can talk about that after. There are markers for future risk, and we see that as women go through the menopause. So there are adverse cardiometabolic changes that occur with menopause. The cholesterol or lipids, abnormal ones, increase, and they become actually more unfavorable for developing of cardiovascular disease. We see increase in blood pressure, rates of hypertension. We see worsening glucose intolerance and increased metabolic syndrome, a clustering of changes in the body that puts one at risk for cardiovascular disease. The other thing is that a woman's fat distribution changes at midlife or menopause. We see increased visceral adiposity. And I talk about this, and most of us understand the concept of an apple-shaped central weight. I sometimes call that the Canadian tire, or the pear-shaped. And women, when they are younger, tend to put on fat on their hips and are pear-shaped. That pear-shaped distribution is not as dangerous for our cardiovascular system as the apple shape. With the caveat, you may have heard me say this over the last few decades, you can't be a big pear, because it's actually the weight across your waist, and that's the term, metabolically active fat. That it's the belly fat that's deep inside that causes inflammation, high blood pressure, diabetes.
Can you hear me?
Sorry.
Okay.
And actually, even with when we talk about menopause, we see a lower muscle mass in women, even with normal body mass index. And this all leads to increased cardiovascular risk. So women are at risk as they go through midlife for this. Okay, and this is a picture. So the visceral adiposity is associated with conditions that lead to heart disease. Visceral is inside, you're close to your organs, but it is the apple shape, the Canadian tire, the beer belly, the change in fat distribution that occurs when a woman's estrogen levels fall and estrogen to testosterone ratios change. And then we see an increase in the LDL or lousy cholesterol, decreased good or healthy cholesterol, HDL, and higher triglycerides, a blood fat that is also associated with cardiovascular disease. We see more of a tendency to diabetes, insulin resistance. We see increased insulin levels, which can cause problems, abnormal blood clotting, and we see blood vessel dysfunction, endothelial dysfunction. So what about high blood pressure or hypertension in menopause? Well, it's actually very interesting. There is a steady rise in the top in the systolic blood pressure as we age. But until the age of 65, men have a higher prevalence of high blood pressure than women. After age 65, women have a higher prevalence than men. And if we look at US data, the same holds true for Canada. More than 75% of the US population of women age over 60 and 40% of postmenopausal women have high blood pressure. Think about that. And I just saw a statistic that came across my my email today, because I read I try see the highlights of my journals and the papers, and that we see less than 75% of the US population having controlled blood pressure. If we controlled blood pressure, we'd have more time to in healthcare to avoid having to manage, and we love managing our patients living with heart disease, but we would be controlling heart disease, heart failure tremendously, heart attack and stroke by controlling blood pressure. Now, this is very interesting. I'm going to show you a slide. I think the next slide shows it. There's a steady increase in blood pressure that happens over time, but there's a step up around menopause. And this is a slide that talks about ovarian reserve, so ovaries in women, and blood pressure over a lifespan. This is really interesting. And this is interesting data. If we look at a woman that goes through from childhood to pregnancy to midlife to aging, and we see that normally you'd see a linear rise in blood pressure, but we actually see a step up, so in blood pressure after menopause. And we see that, and there is a clear relationship. It is not just aging. It has to do with ovarian reserve, and it has to do with complicated hormonal situations in the body that raise blood pressure. So how do we fix it? Now, this is an older slide, but it still holds true. This is Time magazine estrogen. Is it the panacea, the wonder drug? And I will start off by saying no. There are colleagues across the country, nationally and internationally, who are experts, who are not necessarily following the science. I'm just going to say that. And if it's complicated for my colleagues to understand what to believe, I can't imagine what it's like for someone who does not have a healthcare background. And so I've had, if you can see the slide, the actual hands look different. One is an older looking hand, more wrinkled, and one is younger looking. In fact, estrogen has multiple effects on the body. And by definition, a hormone, I learned in medical school, has multiple effects on the body. And I have had women over many years say they feel younger and feel better on estrogen. Your skin looks better. And it's often been nurses, and I'm not trying to dismiss the nurses in my practice. They're educated and they're medically sophisticated, but they loved being on estrogen because it made them look better and feel younger. But there's danger in that, and we're going to talk about that. It's not something for everyone, and it's not used to make us feel younger or look better. Shouldn't be. In fact, if we look at this, it's how we discuss science and how we look at trials. So the older studies suggested there was a benefit, a cardiovascular benefit from women taking estrogen, but these are what we call observational studies, and they're at risk of having problems that we call confounding. Because the women, the nurses in my practice, who chose to take menopausal hormone therapy were better educated, had usually a higher socioeconomic status, and they had greater access to other healthcare resources and treatment for their risk factors. So those who sought menopausal hormone therapy were more likely to adhere to other wellness advice. They tended to be leaner and exercise more. And women who became sick with other conditions were more likely to stop their hormones. So they appeared to have more deaths in the non-users than the users. And as a consequence, the observational studies misled us to say estrogen was beneficial and not being on estrogen wasn't. But if we look at this and we look at, there were various randomized controlled trials, and there is something we call a Cochrane analysis, a very large overview or analysis that we look at in medicine. And this was done several years ago, looking at the randomized trials, looking at menopausal hormone therapy and cardiovascular disease. It did suggest that if we started estrogen and progesterone menopausal hormone therapy within 10 years after menopause, there seemed to be a reduction in cardiac events. But we saw an increase in blood clots. That VTE is venous thromboembolism. And if you can see, it actually caused significant venous thromboembolism. And although we saw a reduction in death from heart attack, there was no difference in all-cause death, because women, as can men, can die from clots from their lungs, from venous thromboembolism. So there was no difference in preventing death with these hormones, okay? And I want to show the slide about this. Most of the data comes from the Women's Health Initiative, and people out there, the influencers, the people who don't believe the scientific data entirely, say, hey, wait a minute. This is with oral estrogen. We have other forms of estrogen, and we have other ways to treat women. But I do want to point something out. I don't want you to have the scientific slide to show you anything than these top 3 lines here. This is coronary heart disease, actually this is breast cancer and stroke. And these are clots to the lungs. And all I want you to see is the size of these lines. You don't have to look. The dark was the estrogen, light was placebo. But younger women had lower rates of side effects. But as we age, and I'd still say this is young, but in women aged 60 to 69, you can see that these lines are bigger. And by the time women have become slightly older, 70, 79, even if they're not taking estrogen, risks for heart attack, for stroke, and for clotting are higher. And what you can see is that the women who are older who took estrogen and progesterone had significantly higher risk of coronary heart disease and stroke. And we do not, and actually even more so if we look at it for estrogen alone. So if a woman has had a hysterectomy, we give people, and we give women progesterone to protect them from endometrial cancer so they can slough their lining. Otherwise, their estrogen keeps building up and growing in their womb. So as a consequence, women who've had a hysterectomy can be on estrogen alone. And what this slide clearly shows me is where these guidelines come from. Very important. If you are at midlife or beyond and you are over 60, your risk for clotting and heart attack is high, and higher if you're on hormones. Yes, this is oral estrogen, but we don't have data to say the transdermals are a get out of jail free card. And we're going to talk about that. So when we look at this, we also have a lot of good data. In fact, it's almost 10 years ago that my friend Joanne Manson down at Harvard looked at the all-cause death or mortality from this large Women's Health Initiative randomized trial. And what it said is if you're a woman who was at a sort of average risk and took combination hormone therapy for about 5 years, or the estrogen alone, the unopposed estrogen, for about 7.5 years, there was not a lot, and then stopped, you are not at risk for long-term cardiovascular or cancer mortality being followed out. So it is safe for short-term use in the right women for the right reasons. This is not to be used forever. It is not the, people are looking, there's longevity doctors out there, and I have patients coming into my office, and I don't know if there's people online who are using continuous glucose monitors. They're checking their sugars, but they don't have diabetes. So they're just checking. And do we have the science that this is going to make you live longer? No. Give that money to charity and science, because you're spending $100 a month on something that if you don't have diabetes, you don't need. So I'm using that analogy about these longevity, I'm going to look better, feel better, live longer. We have no evidence for that looking at estrogen, but we know it is safe in the right patients for the right duration of time. However, we also know that if women go through early menopause, so if you have a friend, a family member, a colleague, or a patient who's gone through premature menopause, I've told you the average menopause is about 51. So a woman who goes through it under 45, but in their early 40s, there appears to be increased cardiovascular events in these women who do not go on estrogen. So they need to be replaced to midlife. And providing menopausal hormone therapy to this group until the average age of menopause may decrease the risk of adverse cardiac outcomes. These are not randomized trials, but we do believe that replacing women who go through early menopause, it protects their heart, it protects their blood vessels, it protects their bones, it may protect their cognition. We have to look at all of that. So this is the guideline I helped co-chair, the Canadian guidelines, and none of the data has changed and none of the recommendations have changed, despite we can talk about what has happened in the United States with the FDA. Taking a box warning off of estrogen. So this was the chapter from the Society of Obstetricians and Gynecologists of Canada that there's the menopausal clinical practice guidelines. And I looked at with the team, obviously my colleagues, Dr. Black, Christakis, and Fortier and Dr. Wolfman, of course, we looked at menopausal hormone therapy and cardiovascular disease. And we looked at the data. And this was an update from 2014. So we've been looking at this data for a while. And at the end of the day, and these are Canadian guidelines that are consistent with the American guidelines, women who are under 60, who initiate menopausal hormone therapy, do not have increased risk of cardiovascular disease if they, let me back up a bit. Women who initiate menopausal hormone therapy with no increased risk of cardiovascular disease. So you are a healthy woman. You are not a woman attending cardiac rehab. You are a healthy woman. probably and in general are at low risk for adverse events, including stroke in the next few years. I showed you that data. And then we need to say which is the best way to give women estrogen, but it would be safe to give women who are at low risk for cardiovascular disease shorter term estrogen or estrogen and progesterone to deal with their symptoms of menopause. And we'll talk about that. But once you get over 60, and I showed you some of that data, or you give it to women after 10 years after menopause, or women who have higher than average risk of cardiovascular disease, clotting risk is increased. So that venous thromboembolism, we can't get rid of that risk. And stroke risk is increased. And oral and combined hormone preparations are more closely associated with a risk of thrombosis or clotting than with the transdermal or estrogen alone. But no one practicing would ever give somebody an estrogen that's on the skin, even though we think it's less likely to clot, in somebody we know who's at risk for clotting. We just don't have that data. The risk is lower, but it is not zero. So we have to be careful about that. So our Canadian recommendations say that we should offer menopausal hormone therapy as the most effective treatment for relief of menopausal symptoms. One of my first slides talked about that flash, and there's good evidence and high quality data. And I think we should be still talking about the lowest effective dose of estrogen, either oral or on the skin transdermal should be prescribed to minimize the risk of stroke. And there's less data on that. And I'm not going to go into the prescribing slides lower down there, but I've given you the reference to look at. And if we look at summary statements for Canada, so we talked about risk is generally low if women are healthy. And evidence, this is the other thing we put in our guidelines, and this is where cardiac rehab is so vitally important and is in my soul as well, in my heart for many decades. But it's also important from a population perspective to be leading a heart healthy life. We support, and this is true, aggressive risk factor modification of the risk factors are the most effective ways of lowering cardiovascular risk. We do not use menopausal hormone therapy to lower cardiac risk. And we should not be initiating menopausal hormone therapy who are at high risk for cardiovascular events, if women start when they're a little older, because the risk is high. And so we want to, the increased risk of stroke is real and it's identified in all age groups, starting standard menopausal hormone therapy, but in young women, that risk is really low. You know, when we talk about clotting or increased venous thromboembolism risk, I showed you that women over 60 have clotting rates, but there are some other issues that put us at high risk for clotting. So if people are living with being overweight or have a high body mass index, even in other healthy women who are quite overweight will actually have increased risk of clotting, and we have to be cautious for those women. So it is true that menopausal hormone therapy is indicated for the relief of symptoms, but it is not indicated to prevent the first or second heart attack, for the primary or secondary prevention of cardiovascular disease. Blanket statement. There might be even individuals that you hear in the Women's Heart Health Alliance, we can debate another time, on a webinar in 2 weeks that I unfortunately am away with a family with. I won't be able to have a healthy debate, but it is not indicated and there's no data, okay? And women who start menopausal hormone therapy later on are at increased risk. Probably safe in women who are at low risk for short term, and we need to look at more data. So US and Canada can agree on a few things. I will not get political. However, I'm a very proud Canadian. And there is the North American position statement, the Menopause Society. And in the 2022 position statement said the same thing, okay? And our update is saying the same thing. What has happened in the United States, I'm just gonna just show you for a minute, is that the FDA in the United States, run by some individuals, some scientists, some not. As you know, the American Pediatric Society is suing the FDA and the Health Administration for taking away vaccines, because vaccines prevent all sorts of things for our patients, including measles and polio and all sorts of things. So in the US, they took off the blocks warning that there's no harm to hormones in the right patients. And that's probably fair. In the right patients is fair. But that does not mean now that this is the license for women to be saved. I think that was the political gist of it all in the States, that we're doing something for women. We're letting them have their hormones that will make them live forever and feel and look beautiful. That's not, the science hasn't changed. Nothing has changed. Okay. But there are influences out there taking what has happened in the United States to say, well, we should be using hormones. So there are experts on TikTok that are saying where women get health information, they're not necessarily informed of the science. And this is scary because the number of people online tonight, as nice as it is and as thrilled as I am to be here in person, if I can help educate 1, 2, 3, 100, doesn't matter, people, I'm happy to do so. But the influencers have millions of followers, and this is a problem. This is a problem, okay? They're not informed of the science. So let's go over how we do this. So if someone's sweating, assess, is the woman symptomatic? Are they under age 60? Or are they under 10 years from the menopause? Well, if they are, then we're going to show you, sorry, we're going to give them menopausal hormone therapy. But if they're over 60 or more than 10 years, we have to be cautious. And then this is also very an important slide. So if you're at low risk, all right, then you can, to use the term here was menopausal hormone therapy. We used to call it HRT. We're not replacing anything. We're treating symptoms of the menopause. So that's the little nuance. You've heard HRT. It's now MHT. But I'm a cardiologist, so sometimes I think about hypertension. I know that gets confusing. But anyway, menopausal hormone therapy, you've got a green light. If you're having symptoms, and your normal weight, normal blood pressure, you're active, you have low risk, and you're low risk. I didn't go into the breast cancer issue. Fine. We do need to take some caution here in some people who are at risk for heart disease. And this is where it's an individual risk benefit conversation. And I see a lot of that in clinic, in shared clinic. Menopausal hormone therapy should we be using in this woman who's having sweats, and I'm going to go over this. If you have diabetes, if you're smoking, right, we don't give birth control pills, which are higher dose estrogen, but still we don't give that to women, young women who are smoking, because their risk of clotting and stroke is higher. If you're overweight, if you have high cholesterol, have metabolic syndrome, or you're at higher risk, we have to be cautious. That's not a stop sign. That's an individual risk benefit conversation. And if you're at high risk, you know, and if you've had actually coronary artery disease, peripheral arterial disease, if you're someone who's online, who is a patient with lived experience at cardiac rehab here in Toronto or anywhere in the world, you shouldn't be on menopausal hormone therapy. And we're going to talk about what we can do. So what can we do about it? Well, it turns out that we figured out, finally, we have all these 51 billion women in the world. Hopefully there's going to be money where the power is to push the science in terms of investing and figuring out what's going on. We have recently figured out the mechanism for a hot flash. And I am not going to go into a lot of details, but it turns out it's in our brains, in the hypothalamus. There is a receptor. There are neurons. There are nerve cells, okay? And they're called, I'm going to just call them, they're called candy neuron. Kispepsin, neurokinin, dysnorphin, I can't even say it, but they're called candy. It sounds sweet like candy, but there are candy neuron receptors, and they're sensitive to estrogen. Isn't that interesting? Okay. And they regulate our temperature, thermoregulation, and our sleep. Took us a few decades to figure this out, but we're figuring it out. And there is a decline in the way the estrogen signals with menopause, and it can reduce the activity. I won't go into the details of this feedback loop of these neuron receptors, and then they start not working well. And when they start not working well with the signals, women have sweats or hot flashes and sleep disturbances. So guess what? There's actually a drug out there that now interferes with this candy neuron receptor. There is a drug that's been approved since July for Health Canada, FDA approved, safe drug. We can talk about it. I think cardiologists, I think there will be a few of us across the world. I'm not sure cardiologists will be prescribing as much as some of us with an expertise in women and heart disease, but family doctors, gynecologists, endocrinologists can prescribe this drug that blocks in different ways this candy neuron receptor, okay? And what it does, and Health Canada has just approved it hot off the presses, and I put it, I'm sorry, I'm putting up the trade name and the generic name because I think it's important for us to understand both. I'm not here to sell a drug, but I'm here for us to be informed. It is indicated for the treatment of moderate to severe flushing. So that's when we use hormones for vasomotor symptoms of the menopause. But if you're living with heart disease or you've had a stroke, I would be very unhappy trying to prescribe that to you, but I want to take care of your symptoms, because everything in medicine, and specifically in cardiovascular medicine, we're really lucky. I tell the trainees, we want to improve someone's quality of life and quality of life, how long they live and how well they feel. In cardiology and cardiovascular medicine, we often can do that, right? If you're not breathing well with congestive heart failure, we have treatments. We also have treatments that make you live longer and feel better. So we don't have, the estrogen will not make a woman living with heart disease live longer, but will make her feel better. But now we have a safer choice, and we can prescribe this, and it's actually in the context of some expensive cholesterol medications that people have access to, not as expensive a medication in the big picture, but it is approved by Health Canada. But I want to end with the basics. So we have some new interesting science here. But this is the simple 8. Whether we talk about, I'm not trying to be too anti-US. I do have friends and family and colleagues and scientists across and clinicians across the world and in the United States. But the American Heart Association switched from the simple 7 to simple 8. And the 8 is the last one, get healthy sleep. But I think this is important for all of us to prevent heart disease and to help people who are living with heart disease with different necessary parameters and targets, and to lead a healthy life. We have to help people avoid smoking and help them quit smoking. We need to normalize blood pressure, blood sugar, treat cholesterol, avoidance of being overweight, and eat a healthy diet low in saturated fats. Again, there's a lot of, dare I say, misinformation out there on the internet. All right, and exercise regularly. 150 minutes of physical activity a week. That does not mean you have to put on spandex and join a gym. If you are lucky enough to attend a cardiac prevention or rehab program, that's great, but walking in spurts of 10 minutes at a time. And I say for people at different stages of their life, we can do different things. It's never too early or too late to make a lifestyle change. But you know what? If you're walking somewhere and you're driving, let's park at the furthest part. Let's not wait for, I know, okay, I can't say that actually in Canada right now with minus 24 with wind chill. If you want to wait for a parking spot, fine. But when it's not minus 24 with wind chill from 0 degrees centigrade and above, let's park further away, okay? Let's walk. Let's incorporate activity into our everyday lives. That will help us with our cardiovascular health, prevent and deal with heart disease. And this is the 8th, is getting sleep. And we're not good at getting healthy sleep. And we're busy thinking about things and doing things, and the state of the world being upside down, or women living through midlife are sweating. And we need to make sure we're dealing with healthy sleep. And I will end there and have time for some Q&A. I was fortunate to be one of the, we are moving science. We wrote a chapter. I was an author in a chapter of one of the first textbooks on women and cardiovascular disease internationally that's just come out in the last few years. And one of my previous fellows, Dr. Kijeni Srivatharaja, who's out in Hamilton and McMaster, I helped co-author that. And with that, I will end, and happy to take questions. And I'll let the people in front of me deal with the media, because I with the Q&A. I preface this by telling you I will never answer a personal health question. I know people know that, but I will be polite, but just not answer your question if you ask me that, when I give talks to the general public as well.
Thank you very much, Dr. Abramson. Excellent, informative and talk. And we just want to remind everyone online, please raise your hand or put your questions in the chat. And we have Lisa, who is going to be helping moderate. And in the room, we will open up for questions. So please feel free to send your questions. Just a reminder as well, while people are thinking about their questions, we will be recording. This session is being recorded. So we will be sending this out after, if you happen to miss some of it. And it will also be posted on our Cardiac College Women's Cardiac College site as well. Okay. Questions? Yes.
I'll repeat it after. Yes.
You can ask.
Okay, so that's a good question. The question in the audience was, are the vasomotor symptoms, is the sweating related to cardiovascular disease? And there is some data from the SWAN study suggesting it is a marker for risk and is associated with increased risk. And why that is not clear. I would say, however, that if those severe sweating symptoms or flushing vasomotor symptoms, if a woman has that, it's not a death sentence in terms of cardiovascular disease. It means pay attention to your blood pressure, pay attention to your cholesterol, pay attention to your blood sugar, and lead a heart healthy life. But there is an association. We've seen that in the SWAN study. Yes. Yes.
So if some of our female patients here in the cardiac rehab program are in fact on MHT, and we've sort of said that they shouldn't be,
yes,
what should they do?
Okay, so that's a really good question. So let's go over this. And the question, I don't know if it repeated, if you have heart disease and you're at cardiac rehab and you're on menopausal hormone therapy and your doctors are saying come off of it and you say, no way, I can't live without it, what should we do? Well, so I would say, as in life and everything, it depends. And we have to individual patient-informed decision making. However, I would say that there's a lot of data that suggests the first conversation is why you're taking it and when you started it. Those would be my first thing. So if someone's taking it because they want to keep their bones strong, and that's actually an indication in the United States that we don't have as frequently here in Canada, there are other drugs to keep our bones strong. And so the person living with heart disease, the woman living with heart disease, should not be on that hormone therapy to keep their bones strong. There are a whole host of other drugs. If they are on it for anything other than severe sweating or flushing symptoms for quality of life, for midlife and menopause, I would suggest coming off of it. People can have mood-related issues, and people talk about brain fog and a whole host of things, but we do have other therapies that we can use if need be to help women for that, and these are specific women who are at higher risk for recurrent heart attack and stroke. However, I will also preface it that if a woman has been on menopausal hormone therapy for symptoms, for flushing and symptoms of the menopause, although they're I would say the unfortunate 10 to 15% of women who have severe flushing for a prolonged period of time, most women, 80% of women, 85% of women, will have lower flushing risk the further you go out from menopause. So if this woman was put on it 5 years ago or 10 years ago, it's time to have a trial off and see where you are. So it doesn't mean that the symptoms will be the same if time has passed. And statistically speaking, and we have to individualize and try it with that woman, that person will actually probably have less severe symptoms of menopause. And so there's moderate to severe, and then there's mild, and then there's what else can we do about it? Because we can do other things. And I know it sounds inconvenient, but wearing lighter clothing and having a fan at night, especially if we're talking about something that could put you at risk for stroke. Having said that, these new candy neuron receptor drugs, if we get our patients who need to be we want them to have good quality of life. So if we do have women living with heart disease and cardiovascular disease who are in that red box at higher risk for menopausal hormone therapy, I would say trying these new candy neuron receptors is very appropriate. Some people will say that everything I'm talking about is about oral estrogen pills, and that we don't have the same. I would say we don't have the same. We don't have the same data for the transdermal estrogens. There are patches, and there are gels, and those types of estrogens do not go through the liver and cause clotting. The first pass analysis, and to clotting. That is true to some degree, but it is not on a red label, a black label saying it does not cause clotting. And we actually do have still data that shows that even transdermal estrogens, although less so, still cause high blood pressure and a change in blood, a whole host of things. So I would say for that woman who's having severe sweating, that and comes off of it and is still having severe sweating, I think a trial off is fair. And if there's the candy neuron receptors or a conversation about the transdermal estrogens, I don't think so. The conversation is the lack of science doesn't mean we shouldn't be treating women. I think we have to individualize it. I don't think we can have blanket statements. And this is where we're talking about a woman with symptoms and vasomotor symptoms of the menopause. We're not using it to get a woman's hands looking younger and feeling better for longevity. And I think that's where we have to have a conversation. And we have no data no data, certainly not with transdermal either, that estrogens prevent heart disease, period. Because when we look at data that looks at short-term outcomes, the thickening of the arteries, the reactivity of the arteries, a lot of studies suggest putting women on estrogens, transdermal and oral, make the arteries healthier. But the minute you take those women off of that estrogen, the artery and arterial stiffness changes again. And as I've told you, this is not a lifelong treatment. So that's a long-winded answer to my question.
Okay, so we have a question in the chat. Some of us on the call have had SCADs.
Yes.
Does the guidance you've talked about change for this type of heart event? Also, is progesterone, example in IUD, risky?
Okay, so SCAD, which is sudden coronary artery dissection, spontaneous, is an important and unique. I'm sorry if there's some PID on there. You just okay, yeah, that's muted them. Thank you. Sorry, I was just going to say, and we can mute our videos too, so it's not too distracting at times. If you're not asking a question, please. So SCAD is an important and unique type of heart disease that women can have. The problem is that we don't know enough. And because before we learned about SCAD, I learned 25 years ago as a cardiology resident that pregnant women get dissections of their coronary arteries, that there is an association between estrogen and how our arteries are affected. I would be, and most of the guidelines, it doesn't talk specifically to SCAD, but women with SCAD should not be on estrogen. I would not feel comfortable. I would not feel comfortable. I'd have an individual conversation. I would not even feel comfortable with transdermal replacement in a woman with SCAD for those reasons, because we just don't know enough. It's an area of ongoing research, and we need to know more, but we don't want to do any harm, right? So estrogen can cause problems with blood vessels in high doses. So, and then the progesterone comment, we don't know enough, but IUDs in general, locally, are probably safer. It is the estrogen and the oral progesterones that may cause problems. So I think that is fine, but I hope that answers the SCAD question. I wish I had a better answer for all our patients living with SCAD.
I know we said that we don't like to do blanket statements. I'm just curious if young, healthy, and either spontaneous or surgical early or premature menopause, if there's a contraindication or indication for those women. So you said if they're young and healthy.
So if they're young and healthy,
yeah,
and they don't have heart disease and they go through early menopause, premature menopause, we do want them replaced. Okay. Absolutely, for their heart, their bones. So for some people, we've got people with lived experience on the call. We also have healthcare providers, and sometimes you'll go into an office and do something called a calculation of future risk, of Framingham risk score. Women, I always take, so that you've heard about the sex-specific risk factors that we all have to ask. Have you had high blood pressure or diabetes with your pregnancy? And when did you go through midlife or menopause? Because if you went through 40 and you weren't replaced, from the inside, not from how people look on the outside, but from the inside, from your blood vessels, you're 10 years older. So if a woman goes through menopause at 40, that's 10 years earlier, and I see them at 60, she's actually 70. She's 10 years older on the inside from their blood vessels. So we do replace those women. Okay. I think we're done. I think we're one last. It's up to you. I'm happy to answer.
Sure.
Yeah.
But I think one of the things that I'm hearing that's recurring, and I see it myself in my own area of research, is that we just don't have the data. And I do think we have to move away from blanket statements of, hormone therapy is good or bad.
No, it's individualized. So I'm going to repeat that we have to individualize.
The largest headline was NPA, and so that's where we have all of this.
Right.
But other clinicians, we need those.
So I'm going to repeat this for the audience, because there are a lot of people online, that we need more data in terms of the roots of estrogen. I am not saying all estrogens are good or all estrogens are bad, but I am saying for now, and I'm making this a safe, there is no evidence, even with the transdermal estrogens, that they prevent heart disease, and they should be, or should they, for the primary, secondary prevention of heart disease, because we just are not going to use that. But we have risk benefit, and even with the transdermals, it's not something, is again a longevity concept. Should we all be on it? But I will say one thing though, what we're talking about here. And we've got a researcher who introduced herself. I'm so excited, on cognition and neuroscience. And this is so important for us all to be talking to each other, because it's the same person, it's the same patient, it's the same woman in front of us, whether I deal with the heart or the brain or the thighs or the hips or whatever, or the bones, whatever. But I will say, for women living with cardiovascular disease, I am making a blanket statement that we don't have good evidence that any form of estrogen is safe. We don't have the evidence, and it's a risk benefit ratio, and we have other options. And I think that is something that people have to understand.
Chandra, go ahead.
Is too much hair fall is due to heart disease?
I'm sorry, say that again.
Say that again.
Is too much hair fall, is it due to heart disease?
Too much alcohol?
No,
Sorry. Do you want it? Sorry. Oh, hair falling out, heart
Oh,
disease. Oh, too much hair. No, not that I'm aware of. A hair falls out from stress. Women get hair fall out during pregnancy. It's not, we won't talk about stress and heart disease now, but no, hair fall. The good news is, but I think what people might be alluding to is that there's male and female patterns of hair loss, but there's no, to my knowledge, there's no issues related to male or female hair loss. It's more male or female weight distribution. You know, as a woman goes through menopause, her body shape changes. And so we just need to make sure, for women and for men, for our friends and family members and patients who are male also, that we worry about that weight across the belly. That's really important.
Yeah. Sorry to sound naive, but the data on the going through menopause in early 40s and the hormone replacement therapy for like within a certain period of time just after that starts is beneficial. This data is how old?
Well, so the question is, how old is the data on women who go through premature menopause? It's older, and it's also not something we do a randomized controlled trial in. Like we wouldn't deny, in science and medicine, we want to help people, so we wouldn't deny them what we think is useful in terms of long-term follow-up, because there's a lot of data on bone loss and there are signals. But it is pretty consistent in all organizations, and cardiovascular, gynecologic, menopause societies do recommend for women who can be replaced with premature menopause. And so this is the challenge when we see women living with who are breast cancer survivors who can't go on it. So that's an area beyond my realm of expertise, but there are women who are being replaced appropriately by experts.
I guess I should have rephrased the question. Is this data less than 20 years old?
It comes from various data. Sorry, what?
25 years ago, was this type of thinking around? Like,
it's been around for a while. It hasn't been commented. It has to. This is why. Yeah, it's been around, but it's not been as widely understood, because again, this is why we have to go red for women. I've been in practice for a few years, and people who have interest in the field know it, but it's something that requires translation of knowledge to primary care providers, to other healthcare providers, and to the public. And even this issue of high blood pressure and diabetes during pregnancies, that data has been around for a while, and I'm very happy to say it's coming to the forefront. So it was around, but was not as commonly understood. I think that's the answer. Yeah.
What you were going through there, I wish I know.
Yeah, I think we move forward. The world is through would have, should have, and could have.
Yeah.
But we now, but you're absolutely right. So what we know now and how we approach things, and science is always evolving, but this is why it's important to talk about it. And you know, the face of heart disease, I said this 20 years ago, the face of heart disease has changed.
Mm-hmm.
I take care of lovely older gray-haired men, but that's not the only face of heart disease anymore. But what hasn't been the face of heart disease for 20 years. So let's go red for women and raise awareness.
Perfect. What a great way to end. Thank you very much, Dr. Abramson.